How do I get to the bar? All right. All right, thank you for joining us. Give us just a minute while we let people filter into the Zoom webinar and we'll get started. All right, let's get started. So I'm Sarah Brewer. I'm the director of our education program here at Accords. I want to welcome you all to our Hot Topics in Mixed Methods seminar series. We're the fourth of our series today. So let's get started with what is Accords. So Accords is our one-stop shop for pragmatic research. It's supported by the University of Colorado School of Medicine and Children's Hospital Colorado. And faculty, fellows, trainees can receive various types of services and support for grants and projects, along with incredible mentorship, training, and education in health services research. So Accords conducts pragmatic research in real-world settings to improve healthcare and outcomes by providing multidisciplinary collaborative research environment, strong methodological cores and programs. And today we're partnered with our Qualitative and Mixed Methods core. We provide consultations and team building, mentorship, training, and support for junior faculty, and extensive educational offerings, of which this seminar is one of our ongoing programs. Before I introduce today's speaker, just a couple of housekeeping items about our seminars. First, please use the chat throughout the seminar for any comments or questions. We will have time for moderated Q&A at the end of the talk. And second, please complete our evaluation at the end of today's seminar. That helps us to make sure we're providing educational offerings that meet your needs. Let's see if we can get our slides going here. There we go. I want to highlight a couple of other upcoming events. So the first is April 26th. We'll have our quarterly community engagement forum, and we're highlighting a partnership. And that talk will be entitled Forging and Funding a Community Partnership, an example of in-tandem partnership. In May, we have the final of our Hot Topics in Mixed Methods with Jody Summers-Holtrop, talking about more complex mixed methods designs and approaches. May 15th, we'll have methods and challenges in conducting health equity research with Dr. April Ho. And then in June 5th and 6th, we have our annual Colorado Pragmatic Research and Health Conference. Registration is open now for that. And next week is our abstract deadline. So if you have posters to submit for CopperCon, now is the time. All right. Today's seminar is, like I said, part of our Hot Topics in Mixed Methods series. And we have Dr. Rupali Limaye with us. Dr. Limaye is an expert in vaccine behavior and decision-making, including vaccine hesitancy and acceptance. She's an associate professor and serves as the deputy director of the International Vaccine Access Center at the Johns Hopkins Bloomberg School of Public Health. Her mixed methods work examines how various influences affect health behavior and how to leverage those influences to affect positive behavior change. She received her PhD from the Johns Hopkins Bloomberg School of Public Health. She holds an MPH in global health, an MA in international affairs, a BA in political science, and a BS in journalism. Please join me in welcoming Dr. Limaye today as she presents using longitudinal qualitative data and cross-sectional quantitative data to understand maternal immunization decision-making. Welcome, Dr. Limaye.
Sure. I promise I will not wander too far. Hi, everyone. It's so nice to meet you. My name is Rupali Limaye. It's great to be here. As Sarah mentioned, I'm an associate professor in the Department of International Health, as well as a joint appointment in our departments of epidemiology and health behavior and society at Johns Hopkins. It's really great to be here. I'm also the associate chair of the department and serve as the deputy director of IVAC. I don't know if anyone has heard, International Vaccine Access Center. So we're an academic center within the school that actually primarily focuses on vaccine access in lower and middle income settings. So what I'm going to talk about today is a project called MIRI, and it stands for Maternal Immunization Readiness Initiative. And the overall goal of this project is that we're really interested in maternal vaccines that are not yet on the market, right? That's the whole purpose behind this. There's sort of three main buckets, I would say, behind this work. So on the very left side, we have immunization readiness, where we have an arm of the study that's particularly looking at health facilities. Are they able to deliver maternal vaccines? The second arm that we focus on is maternal immunization policy. So understanding what sort of policy recommendations are available with regards to permissive or required with regards to different maternal immunization products. And again, we have a website if you're interested in looking at that. And then the third arm, which is the one I'm going to be talking about today, is our demand generation and communication arm. We're interested in understanding attitudes as well as behaviors so that we can think about how do we create demand for maternal vaccines that are not yet on the market. Great. So this is a pretty large and a little bit complicated study. So I'm going to try to kind of break this down a little bit in terms of some of the work and in terms of what we have been doing. And I should mention, we are funded by the Bill and Melinda Gates Foundation. It's a 4-year grant, a little over $5 million. So in terms of this overview of our work, what have we done so far? And I'm not going to talk about the ones in blue, but just so you have a context and understanding. We have conducted research related to demand factors and health system readiness factors in Kenya and Bangladesh, specifically related to RSV vaccines. And I'm sure many of you are well aware that there are 2 probably products, RSV vaccine products, that will be coming on the market relatively soon that'll hopefully be pre-qualified by WHO and will therefore be able to be delivered in the lower and middle income country context. So we're a little bit done with data collection in that phase, and we're currently conducting data analysis. Similarly, we did similar work related to GBS. We're a little bit farther away from this vaccine. I'm sure many of you know, closer probably to 8 to 10 years away. But we were able to talk to a number of different stakeholders, again, in Kenya and Bangladesh, and we're conducting data analysis. The one I'm going to talk about today is in orange. I'm focusing on COVID-19 vaccines given during pregnancy, as well as potential future vaccines that could be given during pregnancy, including tuberculosis, as well as malaria. This is a 5-country study that we are currently working on. So you can see Brazil, Ghana, Kenya, Pakistan, and the Philippines. And our main partner in this work is the World Health Organization, headquarters in Geneva. And please do feel free to stop me if I'm using any acronyms or any terms that do not make sense. Okay, so the study rationale, why are we doing this work to begin with? So I think many of you know, but most pregnant and lactating women have been excluded from COVID-19 vaccine trials. We know that they hold, unfortunately, and experience high rates of morbidity as well as mortality related to COVID. The interesting part throughout the pandemic, what we have seen is that country recommendations have varied with regards to whether or not pregnant women and lactating women should be vaccinated, whether it was permissive, whether it was not allowed, or whether it was required. So there's been really a diverse range of what has been recommended. Even in settings we have seen where COVID-19 vaccination is encouraged, uptake has been really slow among pregnant women. And there's a multitude of reasons behind that, as you can imagine. Those are multifactorial, so those are individual reasons and attitudes. Those are peer influences, community influences, and of course, structural influences, including mandates as well. So with regards to this study aim, what we really want to understand overall is how does vaccine decision-making occur within pregnant women as well as postpartum women in these 5 countries that I just mentioned. On the right, you can see some of the constructs, and I'm going to talk about each of these in a little bit more detail, but we first want to get a sense of how are pregnant women thinking about their risk perception related to COVID, so their severity to the disease as well as susceptibility. We also want to get a sense of what do they know about COVID-19 vaccines in their country, and who do they go to for information with regards to whether or not they're going to accept a COVID-19 vaccine, whether it's during pregnancy or it's postpartum. We also want to get a sense of what are some of the key decision-making factors. This includes norms, knowledge, attitudes, as well as self-efficacy to be able to actually obtain a vaccine. And then the longitudinal piece is really comparing the decision-making process across the various stages of pregnancy. I think many of you know in this room, but the way that you make decisions in first trimester are very different in terms of how you're making decisions in your 3rd trimester, and then obviously after you've had your child. Finally, for some of the quantitative pieces, we'll assess some of the COVID-19 vaccine uptake, and then we'll look at some of these other vaccine intentions for some future vaccines that we're working on in terms of some of our other studies related to TB vaccines as well as malaria vaccines specifically for pregnant women. So the way that this is grounded, I'm a behavioral scientist, so this is very much grounded in a socio-ecological model. One of the key things that we've really learned in terms of some of the barriers related to maternal vaccination is that we know that these decisions are not made in a vacuum. And primarily what's been so fascinating for us is really the 2 levels, I would say, in the middle, the peer influence level, which continues to, I think, evolve, particularly with what happens with COVID, but in addition to future vaccines specifically and new vaccines and novel vaccines as they come on the market. In addition to that, very similar to what you see here in the United States, a healthcare provider, a recommendation from a healthcare provider is really important. But one thing that I will say, particularly working in the international context, is that it's the healthcare workers that are ones that are actually most influential. It's not your doctors, it's not your nurses, it's actually individuals that are living in the communities and are going house to house. So slightly different there. So it's a 5-country study. It's pretty large, I will say that. From a coordination perspective, we really have to think about creatively how to do this with resources as well as personnel. So there's sort of 2 studies that are linked into this. So Hopkins is here at the bottom, which I just talked about, the MIRI study. And what we're using for the MIRI study is that we were really in charge of study design, instrument design, data analysis. We partnered with the WHO because they have this larger COVID-19 longitudinal cohort study where they're essentially collecting data from women in over 12 different countries. And so we're really using the infrastructure of the WHO longitudinal cohort study to be able to move this study forward, just to give you a little bit of that context. So when we started this project, we wanted to think about which countries do we really want to target, right? And so we did a little bit of a landscape analysis to have a better sense of some of the factors to determine which countries we wanted to move ahead with this study. I've listed some of the things here. So you can see, for example, the number of deliveries per year by the study sites in terms of the larger WHO study, whether or not pregnant women were being vaccinated. Again, this was back as of 2021, and what were the different vaccines used during pregnancy. So a complicated factor in all of this, as you can probably imagine, is here in the United States, we essentially had 3 products we could choose from, right? We could either do Pfizer, we could do Moderna, or we could do Johnson & Johnson. In all these other countries, it was a range of different products, and it really had to do with the way that the COVAX mechanism determined how different amounts of the vaccine were given to different countries. So one of the key things that really came up here is that we wanted to think about diversity with regards to vaccine products that were available for COVID-19 vaccination. And we also wanted to think about, obviously, what was the recommendation of the country in terms of country selection, whether they were permissive, whether they were against it, or whether or not they had no policy. So the reason that we chose these countries, I touched on some of these points already, but we wanted to have some geographic diversity. Is everyone familiar with Gavi? People know what Gavi is? Okay. So for lower and middle income settings, the way that countries are able to procure vaccines, right? So that goes through UNICEF. UNICEF is essentially procurement for supply. Gavi is what provides you with co-financing. So at Gavi status, there's different statuses that countries can be in. So for example, if you are sort of a early transition country, you pay for less of the vaccine. It's essentially the proportion of the dose that you pay for. So we wanted to get a sense, again, across Gavi statuses, because it depends. So if you're sort of on, like if you're a Bangladesh, for example, you're going to pay a very fractional amount of a vaccine versus if you're a country that's closer to graduating from Gavi, i.e. India, which is graduated out, you're going to pay 100% of the vaccine, right? So it just has to do with the amount of cost co-financing that you're going to get from Gavi. We also wanted to have a sense of what was the disease burden for COVID specifically, as well as diseases that were affecting pregnant women. A key thing that we wanted to think about was strong political will. So in the global context, what's really important and what we have learned through introduction of HPV vaccine, for example, as well as PCV and Rota vaccines, is that we know that there's leaders in particular regions. So for example, if we can get Rwanda on board for West Africa, the rest of West Africa will follow. So we wanted to think about it within this context with regards to political will, as well as influence in the region. And the map that I have here, this is from our commit website. Essentially what it does is it tracks all the different COVID-19 vaccination policies related to pregnant as well as postpartum women. And so it's interactive. The website is there on the bottom where you can click and you can see what's recommended, if there's qualifications, when it was recommended, when the policy came down from the Ministry of Health, and when it started being implemented at the country level. So the reason we chose these, again, 5 countries is we wanted to have some diversity. So we have Brazil, which is sort of an outlier in my opinion, because it's a middle income country, but it's in the PAHO region. We then have Ghana and Kenya, which are both in the Afro regions. We have Pakistan, which is in EMRO, and Philippines, which is in WIPRO. And essentially at the time, what we wanted to look at is what were their current policies related to COVID-19 vaccination for pregnant and lactating women. And at the time when we started this study, Brazil was very open and was actually one of the first countries that recommended the vaccine for pregnant as well as lactating women. Ghana and Kenya really had no recommendation. Part of that had to do with disease burden in both of those countries, as you can imagine. Really was not a huge amount of COVID happening in 2021. And then in Pakistan and Philippines, they both had permitted the vaccine, but with specific qualifications. And so this is how we ended up choosing these 5 countries. So with regards to what does the design look like? Essentially, there's 2 key activities when you think about this work. In activity A, focuses really on in-depth interviews. So it's a qualitative inquiry consisting of IDIs to understand how vaccine decision-making occurs among pregnant and postpartum women. So what we have done is there's 25 women from each of the 5 countries and they're interviewed twice. So they're interviewed once during pregnancy, and I'll talk about the timing, and then once postpartum, so 6 weeks, within 6 weeks after birth. The second piece is the quantitative cross-sectional survey, and this is used to essentially identify not only some of the attitudinal constructs that really influence decision-making, but what are some of the correlates with vaccine status among these women? And this is, again, just a cross-sectional 1 point in time. And this is only during pregnancy that we're talking to these women. So these are really the 2 key activities, A and B. So people sometimes ask, and I had to actually argue with the funder, why should we do longitudinal qualitative work, right? Why is this important for us? And the way that I think that is easiest to conceptualize this is that we can think about time in sort of 2 different ways, right? We can think about at each point in time, i.e. synchronic, and then the change between those time periods. And I think this is particularly well suited for pregnant women, as many of you know, because your decision-making changes over the course of your pregnancy and after you've given birth. So it really looks beyond this linear type of a focus and allows you to look forward as well as backward. And again, participants' lives are changing, so we want to think about how we capture that in a little bit of a different way. Gates, I will be honest, was a little bit hesitant when we proposed this type of design because they had never seen this design. But we were able to at least convince them the importance of thinking about how attitudes may change over time, particularly with regards to some of these vaccines that are going to be recommended during pregnancy as well as postpartum. And there are some ethical considerations, but I have several slides on that, so I'll hold on that in just a minute. With regards to some of our inclusion criteria, pretty similar across the board. So of course, we want to make sure that people are able to provide consent. Everyone had to be 18 years or older. And then the way that we did sampling is that we looked at trimester. So essentially, we looked at an equal number of participants by trimester for visit. And then for the follow-up visit for the qualitative, they had to be less than 6 weeks postpartum for visit 2, right? On the quantitative side, again, equal number of participants by trimester. But one of the things that we were trying to sample on, and we ran into some issues, and I'll talk about that, was we wanted about half of the women to be vaccinated and half to be unvaccinated. That was, again, this was our ideal sampling frame that we went into in this study. So what does this look like, right? So you can see across, essentially, for each country, how many interviews we were doing by trimester, what was happening at postpartum, and then similarly, what we were doing with the surveys. So all in all, we'll have about 250 in-depth interviews at the end of this, and we'll have about 2,000 surveys complete after this full study is done. Okay. So as I mentioned, because this is an international study that consists of a lot of different partners, we wanted to think and conceptualize how do we work across these partners in a seamless way. So IVAC, Hopkins, we lead the overall study. We lead, of course, our ethics process on our side, the design, management, analysis, and dissemination. I then mentioned we work with WHO headquarters. This includes a number of different divisions within IDB, which is let's see if I remember this. Immunization, vaccines, and biologics is the department that we worked with. They lead 2 of their ethics process, which I'm going to talk about. They helped coordinate with in-country teams, and then they contribute to the data analysis. We then worked also with the WHO in-country partner, and that was usually a university local partner. They lead the in-country IRB process, recruitment, data collection, transcription, translation, data entry into REDCap, and then co-leading the data analysis. So this was something that we obviously had to iron out in a lot of detail, I would say, when we started this study because of the number of partners that were involved in this. So these are just some of the study partners. If you're interested, I won't spend a lot of time on this, but again, these are our key study partners that we've been working with at the country level in each of the 5 countries. So with regards to recruitment, we decided that we wanted to think about how do we do recruitment sort of consistently across the 5 countries. And so we all agreed upon as a study team that we would start participant recruitment only through health facilities. So this starts essentially with an orientation meeting. I had to go to every single country. I had to talk to provincial as well as district health officers and let them know that we're conducting this study, why it's important to conduct this study. So these were the orientation meetings that happened first. We then had to talk to health facility leadership in each of these countries. And then in each country, what we wanted to do is we wanted to have recruitment from facilities from at least 2 different provinces or districts with an equal split between urban and rural. So as you can imagine, these countries are quite diverse. There's a number of different ways that women are accessing care in these different countries. And one of the things we wanted to do is we wanted to think about a kind of an equal split. Recruitment by tiers really differ by country, and I'm going to talk about that in a minute. In most of these countries, they have level 1 through level 6 health facilities. And so we had to kind of, again, think about how we can match them as appropriately as we could to think about across the 5 countries what this looks like in the end. Each country had specific days for recruitment. Every individual was approached. We followed the same approach. And then we also, again, we have these quotas by trimester, as I mentioned. So you saw earlier on, we wanted to get an equal number for the qualitative piece as well as the quantitative piece. And then again, the only follow-up information that we collected was for individuals that were in the qualitative longitudinal. We didn't collect any personal identifying information from individuals that were only enrolled in the quantitative cross-sectional. So with regards to just some of the instruments and what we were trying to figure out, and I've tried to include this, the key sort of differences here. So on the qualitative side, we really wanted to get a sense of what was their awareness of COVID, whether or not they actually were aware what was happening in their community. We wanted to get a sense of their experience related to COVID, not only their own experience, but their family's experience. We wanted to try to understand what was their recommendation at the country level related to vaccination. Any of their vaccine experience, including concerns, whether or not they were offered a vaccine, structural barriers, interpersonal, community barriers. One thing that came out, I think, very clearly because of the amount of misinformation, as you all know, that's happening because of COVID-19 vaccines is that we did decide to include definitely some questions related to social media sources and where people were going to. I don't know if people use WhatsApp here, but this is really key for most of these countries. People are really on WhatsApp and are getting a ton of information, particularly on WhatsApp. We also wanted to get a sense of their other maternal immunization experience. So in every one of these countries, tetanus toxoid is recommended during pregnancy and is currently the only vaccination in most countries outside of the US that is recommended during pregnancy. So we wanted to get a sense of what was that experience? What did they like? What did they not like? And then finally, we wanted to understand their risk perception related to some of these other diseases that we're interested in exploring, i.e. malaria, TB, RSV, and GBS, where we will hopefully have vaccines available for pregnant women relatively soon. On the quantitative side, again, we asked some basic sociodemographic questions. We asked about risk perception to self, as well as risk perception to your unborn baby related to COVID. We asked about self-efficacy, i.e. how confident are you that if you went to a health facility or a clinic, you would be able to acquire and get a COVID-19 vaccine. We then asked about descriptive and injunctive norms, i.e. what do you think other women are doing, i.e. what do you think other people think you should be doing? And then from there, we also asked specifically about information sources, whether or not they thought the vaccine was effective for them, or whether they whether or not they thought the vaccine was effective for their unborn child. Similarly with safety, we did measure hesitancy. And then we also looked at COVID-19 vaccine behavior, because as I mentioned, each of these countries were in a little bit of a different time frame with regards to rollout of the COVID-19 vaccine. And then, of course, the interest in a future maternal vaccine, where we used a discrete choice experiment. So why do I care about future vaccines? I feel like I get asked this question. And one of the things, as someone that works on 2 large grants that looks at decision-making for introduction of new vaccines in a country's EPI portfolio, vaccine introduction is really complex, particularly in lower and middle income settings, right? There's a number of factors. And one thing I think that is so critical to think about is that most of the factors, if you talk to people that are making these decisions, is that they're not necessarily rational, to be quite honest with you, right? They're usually driven by some sort of a political issue as to why they're going to recommend a specific antigen or a specific vaccine into their country's EPI portfolio. So we have been working very carefully, particularly those related to the different vaccine manufacturers, for example, WHO, Gavi, and UNICEF. They're called the Vaccine Alliance, very important in the lower and middle income context. The Ministry of Health, as well as the Ministry of Finance, RITAGs and NITAGs. So those are essentially your immunization boards, essentially like your ACIP that you would have here, right? But this is in other countries. So you either have a RITAG, which is a regional advisory network, or a NITAG, which is at the country level. And then, of course, professional organizations as well for healthcare workers. And the reason we wanted to think about future vaccines is that we've obviously seen this huge erosion of trust with regards to vaccination. We're seeing anti-science sort of constructs really come up. We're seeing science denialism, not only here in the United States, but unfortunately, everywhere else in the world. It has sort of unfortunately made its way across the globe. And one of the things that we wanted to think about is that I think there was a lot of lessons that we learned during COVID. And I think we were talking this morning, please don't look at the US as a great example, because we're not a great example. And so I think moving forward, how do we think about some of these lessons learned, particularly with regards to delivery at adult and adolescents, that we can apply to some of these future vaccines? And so that's the reason why we were so interested in some of this other work. And with regards to what this looks like in terms of future vaccines, we did something called, we used discrete choice. I don't know if folks have used this type of a decision-making factor before. Essentially, what you do is you force people to make a decision between 2 different attributes. So for example, I could say something like, how important, what is more important to you, that the vaccine protects against the disease by 90%, or that the duration of protection is 3 months? So essentially, it forces you to look at the different vaccine attributes and really tell me, relatively speaking, which one is more important to you with regards to vaccine acceptance. And so it's called the discrete choice experiment, if no one has done that before. So we added that to our survey. One thing that was really interesting that we heard, particularly as we were working on instrument development, that came up a lot that people wanted to know, was the vaccine origin. I don't know if folks are sort of familiar with sort of the drama and misinformation that's gone along with regards to the Russian vaccines. And some of the Chinese products and the Indian products, but this has been a huge issue for COVID-19 vaccine uptake. And as we're starting to see local manufacturers play a bigger role, not only with regards to COVID, but with regards to other antigens, it's going to be really critical to think about the source of origin, unfortunately, because people have very strong feelings about whether or not their vaccine came from Russia. So just a couple of points on why discrete choice. As I mentioned, it's just a different technique that you can use for eliciting different preferences, again, to try to understand relatively what someone is more interested in, what they provide essentially more weight to. With regards to the theoretical foundation, I will say that there are some drawbacks to this. It's essentially looking at utility theory, but that means that we do assume that there's economic rationality, which, questionable if whether or not we think people are making vaccine decisions through this type of a lens. So just some of the biases with regards to using discrete choice. So how did we develop these instruments, right? So we had a qualitative component that has 2 time points. Then we had a quantitative component, which was the cross-sectional piece. First, we started with a literature search that looked at maternal immunization decision-making in LMIC. From there, it was really kind of a long, I would say, iterative development process. So it included, of course, investigators at Hopkins. We worked closely with our counterparts at WHO headquarters in Geneva. And then we also engaged with all of the in-country local investigators across those 5 countries. For each instrument, instruments were at least in 2 languages plus English. So this took a little bit of time, as you can imagine, because we had to make sure we had to get certificate of translations as well. We then had to revise for accuracy quite a bit because of local terms of what people were calling specific things. And this took a little bit of time as well. And then we pre-tested the instruments among pregnant and postpartum people in each country. So I want to talk just really briefly about this kind of a design and some of the ethical considerations to continue that do pop up and something that you have to, I think, mitigate and deal with. One thing that was very important to us, because the qualitative is longitudinal, and this came up very early for us, if we talk to a woman that perhaps in her second trimester at 0.1, and if the follow-up, if she had a miscarriage or stillbirth, do we include her in the study? This took probably 3 months to resolve. Countries had very specific preferences with regards to whether or not we should include women. For example, our colleagues in Brazil were like, well, we still want to know the decision-making process if you've lost a child, versus our colleagues in Kenya said, we should not approach these women at all, right? So from an ethical perspective, from a Hopkins perspective, we also wanted to consult with our IRB as to what is appropriate. So is that lost to follow up, right? If we do have a woman that unfortunately has a miscarriage or has a stillbirth, that was a key issue. Another thing with regards to eligibility, we decided to keep our eligibility range for postpartum relatively narrow, so less than 6 weeks. And again, there was some discussion, should we extend this to 12 months? What should we do? But we decided at the end to keep it to less than 6 weeks. A key piece of this is in Pakistan, unfortunately. We unfortunately dealt with this issue that male partners had to give approval for their wives or their female partners to consent. And so we were not able to get around this. We understand that this is not going to be, it's going to be a little bit of a biased sample with regards to women that are included from the Pakistan site specifically. Then there was a huge discussion, as you know, can we call them pregnant women or can we call them pregnant people? And as you can imagine, us coming from sort of the US space, we're very much like, we need to use inclusive language. WHO obviously is very focused on using inclusive language, but this was quite a little bit of a back and forth. People did not understand why they could not use pregnant women. And then similarly with some of the terms, Ghana was very hung up on this idea, do we call people who are recently pregnant or do we call people nursing mothers? And again, not all women are nursing, so just some of the ethical considerations to continue. From a quantitative perspective, some of the challenges that we had, vaccine status, again, as I mentioned, our sampling frame was looking at about half unvaccinated women and half vaccinated. We dealt with this very early on because in Brazil, more than 90% are vaccinated. So we had to, again, rethink of how do we sample? Do we actually try to meet our quota of 50-50? Or do we go ahead and let them have a little bit of a skewed sample and think about how we do the analysis on the back end? This was a key challenge. As you can imagine, age of majority varies by country. As many of you know, in certain countries, particularly in sub-Saharan Africa, 16, you're considered an adult. We decided to go with the default of 18 because especially our IRB and Hopkins was like, absolutely not. So we will start with 18 as your minimum. Again, male partner approval in Pakistan on the quantitative side. The other thing that came out was really interesting. We have some questions in there specifically when we're asking about hesitancy, whether or not individuals have concern about a vaccine versus concern about ingredients. And the Pakistan team really wanted to detail out every single ingredient in the COVID-19 vaccine. And we were like, well, we can't do that. But maybe we can do a little bit of a broader answer choice category for you to make this easier. The other interesting thing from our Pakistan colleagues, they did not want to include single as a marital status because they're like, why would you be pregnant if you're single? So again, a little bit of a navigational challenge for us that we had to think through. How do we frame this? But we got through that. Ethnicity was another key piece to think about in Kenya. And then another one in Pakistan, which was really fascinating, is that a lot of the feedback we received is that most women don't know if they've been vaccinated against COVID because the male partner is the one that is consenting for them and they don't know what vaccine they received. So again, a little bit of a concern. How do we understand if we're talking to a woman and we're asking about their vaccine decision-making process during COVID, they're not really sure if they've gotten a COVID-19 vaccine or not to begin with. So this is what the ethics review process looks like. Yes, I think most people just sigh when I usually show this slide. As I sigh, I won't lie. It's not the funnest process that we had to go through, but essentially what this looks like is it starts with pre-approval with something called RP2, which is WHO's sort of review panel. What's fascinating to me about this is that the WHO review panel that looks at your study, they're not scientists. So the feedback that you receive is very interesting, is the word I'm going to use here, right? With what you get here. From there, From the Hopkins perspective, we have to get conditional approval, which I think is very similar to most other countries, where you submit everything and they go back and forth. And then essentially you get something called an administrative approval until you get the in-country approval, but you have to do this kind of early on. From there, we then had to get WHO individual country approval, which is different than the RP2 process that happens at the headquarter level. We then had to get approval at the in-country local IRB. Then there's another ethical review that WHO does called ERC, and that's called their Ethics Review Committee, which is actually comprised of scientists that take a look at everything. And then finally, you would get then ethical approval at the Hopkins side. So all this to say is like, this is a little bit of a nightmare, but I think thinking about, global health work and how do we do this type of work is that you have to make sure that you build in enough time to be able to go through all these processes. So what did this look like in practice? And again, people just sigh when I say this. So admin approval from the Hopkins level took about 3 months. It was a lot of back and forth, but it wasn't terrible. We had to submit a different IRB for each country, right? So this was 5 protocols that we put in. The RP2 process at the headquarter level took a full year. So we got funded, team, at the end of 2020, right? End of 2021 for this one specifically. We immediately put in the Hopkins approval. We then had to essentially wait a year to get approval from the headquarter level at WHO, because it was a lot of back and forth. Then the in-country review, which is currently what we're dealing with now and we're about done, was about 3 months. It wasn't terrible. Then local in-country, which is happening. And then finally, at the end of all of this, in July of this year, our last country, i.e. the Philippines, will be approved. So we started in 2022. We will finally be done, 18 months later with just the ethical review process of this. So all I'm saying is that if you're interested in this kind of work, make sure you build some time because this takes a little bit longer that you really want to. With regards to data collection, essentially what we did is one of our junior faculty members is going out and we've developed SOPs for each country. As you can imagine, things are slightly different. We have developed a 4-day in-country data collector training, which includes sort of a didactic focus for the first 2 days and then experiential for the 3rd and the 4th day. We also developed sort of job aids for data collection for specific terms. Again, we're dealing with a lot of low literate audiences. And so we essentially had to draw different visuals when we're talking about specific things so that women understood what we were talking about. And then usually what we have agreed upon is that there's a Hopkins person in country for the first week of data collection. And from that, we do daily debriefs as well as a daily download of data. And you can just see, for example, this is just from one of our training slides with regards to how to talk about a Likert scale and why it's important to think about a 4-point Likert scale versus a 5-point Likert scale for attitudes. And I argue about this all the time with people. I will get on my soapbox. Force people, they have attitudes, they have opinions, force them to tell you, don't give them the don't know option. So I'm just throwing that out there. In terms of data collection and how this happens in terms of at the field level and for storage. So what was great is that everyone agreed to use REDCap, which I think people probably are familiar with here, except for Kenya and Philippines, they really wanted to use paper. So we're using paper data collection in those 2 countries, REDCap for the other 3. So what we decided is that we'll store all the data on REDCap that'll be housed at Hopkins. And then for paper data collection, we agreed upon a 2-step really verification for data entry. And then the paper data, of course, is stored. And you can just see, again, on the right side, this is just one of the checklists that we include in the SOPs before data collection, what we're asking individuals to do that they have to click before they start actually collecting data in their country. So in terms of the timeline, as I mentioned, this is actually really good timing. Sarah told me not to focus on results. I was like, this is the perfect study because we don't have any results yet. What's great about it is we're actually starting Brazil data collection this month, finally. And then we have a little bit of a break in May, and then sort of month by month, we have Ghana, Kenya, Pakistan, and Philippines. So our goal is that analysis will be complete by June of 2024, and that we'll do dissemination in September, probably fall of that year of 2024 is our goal. So yeah, kind of a long time frame, right? That this is really worked on. With regards to what happens right after we have this data and we've gone through the analysis. One of the things that we're trying to focus on, again, COVID to me is just an example of how we can think about future vaccines. So how do we use some of the data from this, from the discrete choice experiment, from the 2 pieces that we're talking about in terms of decision-making, from the 2 qualitative longitudinal time points, as well as the cross-sectional, to think about how do we tailor some of this work for specific audiences. As I mentioned, in a number of my studies, we're sort of antigen agnostic, right? We're essentially advising countries on how they maximize and optimize their EPI portfolio. The biggest ethical concern that we have about this is that we don't want to pit one vaccine against another, right? So a malaria vaccine, I'm sure you guys have heard, RTSS has come out. It's not great. It's 4 doses. It's very expensive. However, what we are hearing at the country level is that countries are preferring the malaria vaccine over an HPV vaccine because they know malaria. It's also not controversial. So the key part about all of this is thinking about how do we develop materials for these different policymakers as well as beneficiaries at the end of all of this, so that when a TB vaccine is available, when a malaria vaccine, an RSV, a GBS vaccine, we have something that we can really think about so that we're not starting from scratch with regards to demand generation. And I try to, I have this quote. So I started my work actually in HIV and AIDS, and I lived primarily overseas. I lived in Malawi for a year. That's where I did my dissertation. And before that, I was working still in Southern Africa, and I still remember when male circumcision came out as a huge preventive strategy to reduce HIV risk exposure. I don't know if people are familiar with this idea. And I still remember this was back in about 2007 that it was recommended. PEPFAR, USAID, WHO was like, great, we're going to include male circumcision as a part of your comprehensive HIV risk reduction strategy. And it was this whole idea that they were like, great, just offer it in clinics and men are going to show up. Not really how it went. I was living in Tanzania at the time, and I was like, there was no demand built for this. And yes, we have made progress with regards to acceptance related to male circumcision, particularly in high burden settings and high prevalence settings, related to HIV. But one of the things that I think is really important, and we're starting to hear particularly among pregnant women with some of our RSV work, one key thing that has come out is one question that a woman had was she was like, wait, is this going to prevent RSV? Or is it just going to prevent severity of RSV? Because we got lied to about COVID. So my point is that hesitancy is not only an issue here, but we're hearing it now, essentially because of what happened with COVID and this erosion of distrust. And so thinking about how do we generate some of this demand before these vaccines are even available is really critical, and one of the reasons that we're really moving ahead with this study. So I just want to acknowledge sort of the Hopkins team, as you can imagine, and I'm happy to talk about how this works from a coordination perspective. I essentially told Sarah it's a nightmare, but one great thing about it and the way that we've been able to really focus on this is that we have sort of key points for each country on the Hopkins side. We have similar key points at the headquarters side for WHO, as well as the in-country, and that's how we've been able to coordinate a bit of a massive undertaking, if you will. But I just want to acknowledge the rest of the team that has been working behind the scenes. And then if you are interested in this project specifically, we've done quite a bit of work related to COVID already, and we're analyzing the RSV and GBS work. So that should be coming out in the next several months as well. But this is just some of our publications if you have any interest in terms of some of this work related to maternal vaccine decision-making. So thank you so much.
Thank you so much. And because right, thank you. That was so I'm really interested in how your group moves from the messages and quality of information you get to the message, because that is, we do a lot of that work ourselves and deciding how to make the messages, that expertise and I really love the experience.
Yeah. No, thank you so much for that question. Do I need to do anything?
Someone was the question. The
Oh,
mic is not working.
The mic is not working. Okay. So specifically asked about message development and how do we think about the expertise related to message development was the question. What I think is so fantastic about this work, and we're getting to do this with RSV and GBS. So the way that we started was we collected data for those two antigens specifically. We talked to pregnant women, we talked to their partners, we talked to community leaders, we talked to religious leaders, we talked to healthcare workers and policymakers. And now we're doing something called a co-creation process. I don't know if folks are familiar with this. So we're heading out to Kenya and Bangladesh in August, where we'll start the co-creation process with the ministries of health. So the goal is going to be, we're bringing people from those different audiences that we interviewed. We have Ministry of Health people involved, But then we also have CBOs and CSO, civil society organizations involved. And it's going to be a little bit of a long and drawn out process with regards to the messaging, including the appeals that we want to use. But we again argued, particularly when we were applying for this funding, that we think that this is the only way that we can do this, that we have to think about how do we tailor this, that yes, we can say a specific thing and think that this is what's going to be important and is going to move the needle. But I think if you have a religious leader actually say it, it sounds much better than the Ministry of Health saying it. So it's going to be essentially a 6-month, we start in August because we'll go to both countries. And then essentially by March, we will have essentially toolkits developed with regards to RSV and GBS. Again, with the hope that an RSV vaccine is hopefully on the horizon pretty soon. But as you can imagine, working with the Ministries of Health, there's a lot of egos. So that has been also a really great lesson to think about how do you work with folks that might not necessarily study this and have very strong feelings about how to message around specific vaccines. And so, yeah, that's our plan, is using a co-creation process.
Go ahead, Josh.
Oh, and I'll just repeat.
Yeah, we'll just summarize because.
Okay. Mhm. Yeah, a great question. So asking about demand generation and how it's a bit of a backward phrase, excuse me, and what does that look like here versus what does that look like in lower and middle income settings? So, I would say most places that I have been able to travel and particularly talk to women, because women are the ones that are making still the health decisions for the household, whether that's maternal vaccination or even childhood vaccination. What has been fascinating to me is that it was always usually the default, right, that you would get the vaccine. And again, this is from the healthcare worker level. They trust the healthcare worker, they live in the community. They're the ones that are coming house to house, talking to these women, talking to their families. They know them from the community, et cetera. One of the things that we're starting to see, though, is that default, I think, has shifted, particularly over the last 10 to 15 to 20 years in the lower and middle income context. And what I mean by that is that we've seen so much more misinformation pop up because of social media. And one of the things that doctors, I think, are very much grappling with in most of these countries is they're like, what do you mean people aren't going to get the vaccine? I'll tell them to get it, right? And so it's this perspective of a very didactic approach of, unfortunately, it's usually a male doctor, right, that's telling a woman how to do something with regards to her body or her child's body. And I think what has been so fascinating with regards to, again, I took a break from traveling overseas for a while because my kids were so little, and now kind of getting back into it and sort of seeing how this has shifted over time. We think about HIV, I think, is a perfect example and corollary. When PrEP came out, for example, and it's starting to roll out more in lower and middle income settings, we were thinking, oh, this is a no-brainer. People will line up around the block. We didn't see that happen here. We didn't see that happen overseas. We're still not seeing that. We're still not seeing that with PMTCT, with prevention of mother to child transmission, and the therapeutics that we have now to be able to prevent that transmission from happening. And so I think in the lower and middle income setting, there's been also a lot of political sort of misinformation, I would say, and a lot of nationalist approaches, as you can imagine, that have sort of shifted the thinking with regards to, again, this increase in science denialism. We're not going to really listen to anything related to science. And so I do think there's actually a bit of a convergence, if you will, with regards to what's happening in the United States and what's happening in lower and middle income context. I think COVID set us back 50 years, unfortunately, in not only here in the States, but everywhere, because of the way that it was rolled out, the way that it was communicated, the types of choices that people were given or not given, really, is what I would say. And also the consent process, right, that was happening overseas. And so I think what's so important about demand generation, right, it's that whole idea of like, if you build it, they will come, right, to give you a Field of Dreams reference. I am that old. But that's not the case, right? And I learned that very at a young age when we were talking about male circumcision, right? Men were not lining up. I don't know why, right? So I think it's very similar with regards, unfortunately, to immunization, which used to be much more, I think, of a default. And some of the work I think that we're using specifically related to this is HPV, because that is such a controversial, I'm going to put that in quotes, vaccine compared to, a PCV vaccine or a rota vaccine or even a typhoid or malaria vaccine, is that we're starting to see a lot more of this pushback and a lot more needs to, similarly here in the United States, we need to identify messengers that are not associated with the healthcare system. Sad that I have to say that, but I think similarly, I think religious leaders specifically have been, I think, so critical, particularly what we learned from COVID in Bangladesh and Kenya, in increasing uptake. And of course, mandates also had an effect. They had vaccine mandates specifically in Kenya, but I think there's unfortunately been a little bit of a convergence, if you will, where I think we thought it was more of an American exceptionalism problem that people were rejecting vaccines. Sort of boiled over a bit, and we're starting to see that, I think, more and more. But yeah, good question. I wish I had a good answer.
Love to talk a little bit more about the longitudinal qualitative, and really kind of thinking about linking those time points and thinking about that change. That's
Yeah, great question. So thinking about the longitudinal qualitative component, as I mentioned, this required a little bit of advocacy from our part to our funder as to why this was important to them. What we'll see moving forward, fingers crossed, is that, again, we're hoping that we'll be able to get an equal number of women during sort of each trimester. And then again, women after postpartum. What I think will be really critical, particularly I think when we talk about specific antigens, is going to be really important. So for example, I think pregnant women in the trimester, when they're first contacted, they're going to have much more to say about RSV, I think, versus postpartum, they might be thinking more about malaria or TB. And so I think, thinking about these different antigens, what's affecting their children at the time is going to be pretty fascinating. And what we've done with the instrument guide specifically for the qualitative pieces is that we do ask some of the same questions related to some of the constructs that I talked about, but then we also ask, like, what's changed since, now that you've given birth, last time we talked to you, you were pregnant. How have you approached this differently? And so we're trying to get a better sense of, like, how has the decision-making evolved over those months that we did not connect with you? And so it'll be interesting to see. I mean, I'm curious, again, as I mentioned, we start with Brazil this month in about 2 weeks. And so we'll start to have follow-up with some of those women in about 6 months or so. So I'd be curious to see. And in terms of how we want to do the analysis, I think we're sort of holding to see what we're going to get first. And then I think we'll come up with a little bit of a better plan depending on what that data look like. Yeah. I don't know if I need to, sorry, I didn't look at the chat at all and I noticed. Okay, I was like,
that's my job. Well, thank you all so much. I'm going to try to stay close to you so that people online can hear also. Thank you all for joining us today. If you are online, the link to our evaluation is in the chat. Please fill that out. And for everyone else, thanks for making the trek across campus and coming to join us. And thank you for coming across the country and sharing your work with us. Thank you, everybody.
Sarah knows, but I'm originally from Kansas, so it's nice to be back in the Midwest.